Hello friends, today's topic is thyroid tumors, chapter 54, Devita. So first we'll see anatomy and physiology. So the name thyroid, it is derived from the Greek term that is shield shaped and which was first introduced by Thomas Wharton in 1656 due to the shape of nearly by thyroid cartilage, and the thyroid is one of the largest endocrine organ, being around 10 to 25 gram, and it is made up of the two lobes connected by an isthmus, and each lobe is approximately 2 centimeter thick and 4 centimeter in length. Although the right lobe may be larger than the left lobe, the gland is made up of follicular cells arranged in a spherical manner, that is follicles, and it is filled with the proteinaceous substance which is known as colloid, and there are parafollicular C cells which are found in the interstitium surrounding the follicles, and they secrete calcitonin. Additional cells within the thyroid nodules include there are additional cells in the thyroid which include lymphocytes, fibroblasts, and adipocyte. Lymphocytes, fibroblast, and adipocyte. And the thyroid is a very vascular gland, with the right lobe exhibiting more vascularity than the left, and the artery supplies from the superior and inferior thyroid arteries. And thyroid drains into superior, middle, and inferior thyroid veins through the venous plexus on the surface of the gland, and this vein then drain into the internal jugular and innominate vein. Thyroid is innervated by the middle and inferior cervical ganglia of the sympathetic nervous system. Now if we talk about thyroid nodule is defined as a discrete lesion in the thyroid gland, and that is radiologically distinct from the surrounding parenchyma. It is very common in general population, and it's ranging from 20 to 76%, and the nodules are more common with increasing age, and particularly in women. Other risk factors include radiation exposure, particularly during childhood, and a family history of the thyroid nodules, and iodine deficiency. Thyroid nodules may not only be discovered by the palpation but may also found incidentally on imaging studies, and approximately 10% of these thyroid nodules are malignant. And in addition to clinical evaluation, high resolution ultrasound of the neck that should be performed if the thyroid nodule are discovered on suspected, and serum TSH. So serum TSH level that should be measured, and if the TSH is suppressed, then the radioactive iodine is uptake and scan should be performed. Radioiodine scan should be performed. And hyperfunctioning nodule, they are rarely malignant. So if TSH is suppressed, that means that it is hyperfunctioning nodule, and in that case malignancy is rare. Therefore further cytological evaluation is not needed if the patient's risk profile is otherwise low. And if cold nodule is present on the scan, then cytological assessment should be considered based on the radiosonographic and the patient's risk factor. So then we'll so if there is cold nodule, we will do ultrasound, we will do cytologic this sonographic features, patient risk factor, and cytology accordingly. And certain features such as presence of microcalcification. So features of microcalcification, then nodular hypoechogenicity, irregular border, nodular vascularity, nodule that is taller than wider on transverse view. They are likely because of the malignancy. So sonographic features like presence of microcalcification, nodular hypoechogenicity, irregular borders, increased vascularity, nodule that is taller than wider. And purely cystic nodules, they are almost benign, and FNA is very sensitive. FNAC is very sensitive with very low risk for to distinguish benign from the malignant nodule. ATA, an American Association of Clinical Endocrinology, and American College of Radiology, and the thyroid reporting, that is TIRADS, thyroid imaging reporting and data system. They provide sonographic risk estimation to guide versus observation of the nodule. And the use of genetic molecular markers, they can help improve diagnosis in an indeterminate lesion. Genetic or molecular markers help to improve diagnosis. And if molecular profile is low for malignancy is less than 4%, then observation may be done in case of indeterminate lesions over surgical intervention in otherwise low intermediate risk nodule. But long-term studies are continuing in this realm, and benign thyroid nodule can be followed conservatively by physical examination or ultrasound unless there are compressive symptoms such as dysphagia or respiratory compromise, at which time surgical management could be considered. And non-diagnostic specimen require repeat FNA, particularly if there are suspicious features, and repeated non-diagnostic FNA may be assessed by surgical excision to obtain diagnosis or monitor depending on the sonographic risk. So if there is thyroid nodule on FNA, we will do FNA. If it is euthyroid, we will do FNA, and if there is insufficient sample, then repeat FNA. If it is benign but there are compressive symptoms, we will go for thyroidectomy. If no, then keep on follow-up. If there is suspicious feature, thyroid lobectomy is performed, intrafrozen is sent, and if turns out malignant, then completion thyroidectomy is done, and in case of malignancy, total thyroidectomy is done. So now incidental PET positive lesion, what we will do in case of PET positive lesion. So normal thyroid tissue, they usually have diffuse low accumulation of this FDG PET. Normal thyroid is having diffuse low FDG accumulation, and FDG positive this PET positive solitary thyroid nodule have an increased risk of malignancy of up to 30 to 50%, and compared to 5 to 10% an incidental thyroid nodule found by other imaging. So however, this lesion should undergo ultrasound guided FNAC. This lesion should undergo ultrasound guided FNAC to exclude the primary or metastatic lesion in the thyroid. And if the TSH is suppressed, so FNAC do, and we will see the TSH. If it is suppressed, then radioactive iodine uptake and scan is indicated. Should go for ultrasound and FNAC, and we will see if the TSH is suppressed, radioactive iodine uptake and scan is indicated, and diffusely increased FDG uptake that does not correlate with the lesion on ultrasound may be an autoimmune thyroid disease, and which usually does not require any further evaluation unless risk for malignancy is suspected. Now what if the malignancy of the thyroid risk factor for thyroid malignancy? If the risk factor, so first is exposure to radiation, particularly in childhood, that is associated with an increased risk of well differentiated thyroid cancer, and the latency period of after childhood exposure is at least 3 to 5 years, and the risk remains apparent for even after 40 years after radiation exposure. And in addition to those who are exposed to the radiation for medical reasons, particularly who have been exposed to nuclear disaster or atomic bomb survivors, there are also increased risk for thyroid cancer. And familial history of thyroid cancer, like in first degree relatives, that is also an important risk factor. And medullary thyroid cancer is associated with familial syndromes, and the only known risk factor for thyroid lymphoma is Hashimoto thyroiditis. Thank you.